Good morning, and thank you for joining Paradigm Biopharmaceuticals presentation of the top line, day 168, quantitative analysis of MRI data from the 008 clinical trial, lodged with the ASX early this morning. My name is Simon White, Director of Investor Relations, and this morning I'm joined by Paradigm's Managing Director, Mr Paul Rennie, Chief Medical Officer, Dr Donna Skerrett, and Global Head of OA, Dr Mukesh Ahuja. All participants will be in listen-only mode. There will be a slide presentation lasting approximately 30 minutes, and any questions today are asked to please be sent to the Investor Relations email at paradigmbiopharma.com, and they will be answered at the conclusion of the webinar. With that in hand, I will hand over to Paul to begin today's presentation. Please go ahead, Paul.
Thank you, Simon, and welcome to everyone, and thank you for taking the time to join. Next slide, please. As an ASX-listed company, we are required to show a disclaimer, and obviously there will be forward-looking statements made throughout the presentation, and there's cautionary notes about such statements. Thank you. Next slide, please. So we're diving straight into the structural improvements at day 168. This is a double-blind, placebo-controlled phase 2 study. So this is Para-008. We spoke last week about the clinical outcomes at day 365. In addition to the clinical outcomes, we're now looking inside the joint through the development of MRI, looking at the joint structures. And we're very pleased to report that iPPS showed improvement in joint structures at day 168, or 6 months, versus placebo in this phase 2 trial. Specifically, we saw improved cartilage volume and cartilage thickness. We saw reduced bone marrow lesion size and volume. And we also saw reduced synovitis. These MRI data are very consistent with the WOMAC pain and function improvements at day 168. They are consistent with the durability and the significant pain reduction and functional improvements at day 365. Also, these data are consistent with the biomarker data that we previously reported at day 56 and day 168. Now, as investors, I would like to just remind you that there is a high unmet need for osteoarthritis therapies. And when you review the literature, many physicians, many researchers refer to the Holy Grail. The Holy Grail of osteoarthritis is a therapeutic product that can, in tandem with the symptomatic improvement of pain and joint function improvement, also provide structural improvement to the joint. In other words, restore cartilage volume, restore cartilage thickness, reduce bone marrow lesions, and reduce synovitis. Doing all of that at the same time. That is the Holy Grail. That is what the market is looking for. So please keep that in mind today as we go through the presentation. Are we addressing a very significant unmet medical need with these data? I hope you agree with us. The answer is a resounding yes. These data will also not only address the needs in the market, but they'll also be very valuable for our regulatory discussions with the FDA and the EMA. And it will also be very important for our commercial partners who are looking for significant advantages over existing therapies so they can take a new, innovative and highly sought after product to market. Obviously, it will make more impact in terms of their sales and their growth of their business if they're able to take a new opportunity with real benefits for physicians and for patients to market. So we're talking to those commercial partners. They understand this, the concept of the combination between symptomatic improvement at the same time as structural improvement. So that's very important. Next slide, please. So I have great pleasure in now talking about the near-term news flow for Paradigm. And I'm also very proud to be able to announce that we've ticked off 2 major milestones, as you can see on this chart. Paradigm has been able to complete the Para-008 phase 2 clinical study showing duration of effect out to 12 months. That data was released to the market last week. And of course, today we released the data around the Para-008 phase 2 clinical study with the 6-month quantitative MRI data. Now, we have DMODE pathways discussions that are coming up with the agencies, both FDA, EMA, in Q1 calendar year 2024. Could I just, again, flag to investors, important point. We are not discussing changing our strategy here, our clinical development strategy. We are simply asking the agencies, do we have sufficient clinical data at this point in time to warrant a disease-modifying label? And if we don't, what would be required to obtain a disease-modifying label? Now, we will not proceed on and extend our timelines or extend our expenditure on that feedback unless the agencies come back and say, we would like to see this type of data reproduced in a larger study, such as our Para-002 stage 2 or our confirmatory study Para-003. We are not changing our strategy. We are not extending our timelines. We are not extending our expenditure. We're simply asking the question, do we have sufficient clinical data at this point to warrant a disease-modifying label? And that, of course, that feedback will be shared with investors when we get that feedback towards the end of Q1 calendar year 2024. TGA provisional approval. So this is something that is now progressing at fast pace as far as the industry is concerned. TGA provisional approval, what does that mean? That means that a company like Paradigm can get approval on the back of good, well-controlled phase 2 data. We don't have to get the phase 3 data before we can get provisional approval. The purpose behind this is agencies like the TGA recognize there are very compelling and very useful therapies that have proven themselves in phase 2. And if the sponsor, Paradigm, agrees to do a phase 3 program, then this provisional approval can be approved to the sponsor's product. And that means earlier revenue for investors. Now, the TGA provisional approval, I explained last week, the process, we've already finished stage 1, which is meeting with the TGA, talking to them in relation to stage 1, which is osteoarthritis a significant disorder? And secondly, is there an unmet medical need with current therapeutic products? And the TGA responded to both of those with, yes, this is osteoarthritis is a major disorder. And secondly, yes, there are obvious limitations with some of the current medications used daily for treating osteoarthritis. We now make a submission to the TGA, hopefully before Christmas this year, where we are going to be explaining to the TGA we have further phase 2 data, and would we qualify or could we proceed to the second stage, which is a determination by the TGA that we can proceed on to stage 2, which means we're able to provide the necessary data for stage 2. What is the necessary data for stage 2? Well, that is that the company needs to be able to demonstrate that the phase 2 data was or is able to show that there is a very significant improvement over current medications. So what we believe we now have with today's data, we have the sufficient evidence in phase 2 to be able to say this is a significant improvement over current medications, in that this is one course of the drug showing 6 months you're getting changes in the disease biomarkers compared to placebo. You're also getting positive changes in the structure of the joint, such as cartilage thickness, cartilage volume, BMLs, and synovitis improvements. And we're also seeing clinical outcomes after one course of the drug out to 12 months. So we think a significant improvement over current medications. If the TGA agree with us, we then get the opportunity to submit a full dossier. A full dossier is all of the information that's required, very much like a full approval. where you're providing all the background on the toxicology results, phase 1, phase 2 studies, the CMC section, the manufacturing and quality sections of the product manufacturer, et cetera, et cetera. And if again the TGA deem that sufficient information, we could see TGA provisional approval. And I say we may see, it's up to the TGA obviously, but we may see TGA approval as early as June 2025. Therefore, revenues would commence after that date, and Paradigm is looking at rolling out its own sales, marketing and distribution for the product in Australia, but we're also in discussions about possibility of partnering that sales, marketing, distribution in Australia. Also coming in terms of news flow, we have the MPS 6 phase 2 clinical trial. The top line data will be out late November, early December. Very important. Again, this is a double-blind, placebo-controlled study in a rare disease. That study is being conducted in Brazil. We'll also be advising the market as soon as we can, read the Para-OA-002, which is our pivotal phase 3 study, in relation to the dose that's being selected for phase 3 progression, as stage 2 of Para-002. And my colleague, Dr. Skerrett, will talk more about that later in the presentation. MPS 1 and Para-008 clinical data have been written up and manuscripts prepared, and they will be sent off for publication sometime, and we hope that they'll be approved for publication sometime calendar year 2024. And as I've said previously, we hope to advise the market at some stage that Paradigm is able to conclude a transaction for the phase 2 asset MPS and our phase 3 asset in osteoarthritis in a regional agreement, such as China, such as Latin America, for example. So with that said, I'll now pass over to my colleague, Dr. Skerrett, who will take us through some background in relation to the study results. Thank you, Donna.
Thank you so much, Paul. So because today's presentation is focused on structural changes in the knee, we thought we'd start out with a little bit of background around the anatomy of the knee and what we're looking at when we evaluate an MRI, and why this is so important in the overall pathophysiology of osteoarthritis, and how we have targeted these various aspects of the knee joint in our program. So on the left, you see the bone, the skeletal depiction of the components of the knee. Those include the bony components, the femur, the tibia, and the patella. And then the smooth lining around them, the cartilage, which is really the primary focus of osteoarthritis, because when that cartilage starts to wear down, that's when we start to see changes in the bone, pain, and other manifestations of osteoarthritis. And in addition to the cartilage and the bone, we have the synovial fluid that is lubricating the joint. And additionally, as you'll hear from us today, when the cartilage wears down and there's wear and tear on the bone, we not only will see that often in terms of bone spurs developing, but then within the subchondral bone, the bone marrow lesion. So we'll be speaking about all of these findings today. On the right side of this slide, we have the similar view of the knee. So a side-on view MRI of the knee showing you the femur or thigh bone, the cartilage then that is between the femur and the tibia. And again, this cartilage and the synovial lubrication are what allow the joint to pivot. And when any one of these is impacted by disease, degeneration, or inflammation, we have various types of dysfunction of the knee. Next slide. So the knee is generally impacted more on the medial compartment from osteoarthritis. That's where the greatest amount of weight wear and tear impacts the knee in osteoarthritis. So we just want to point that out, because in our structural assessments of the joint with MRI, we are able to look at various regions of the joint so we can evaluate the medial compartments separately from the lateral compartments. And you'll hear about various findings in these compartments in the presentation as well. Next slide, please. And then overall, as I mentioned, it's not just the bone, not just the cartilage, and not just the synovial fluid, but how all of these interact together and what are the biochemical processes behind the destruction of the cartilage. We can measure the structural changes, as you see by MRI, and those are depicted in blue in these boxes. We can also measure mediators of pain and inflammation, and we've presented that previously where we evaluated the synovial fluid to look for mediators such as NGF and inflammatory cytokines. And then we can measure the breakdown products of cartilage degradation. So these are very important chemical indicators of what's going on with the cartilage. And we've previously presented those data to you, indicating that PPS has effects that appear to preserve or reduce the degradation of cartilage. So we've evaluated obviously clinical effects through WOMAC pain and function and PGIC. We've looked at the serum measures of these biomarkers. We've looked at synovial measures, and we've now looked at structural methods by quantitative MRI, and those data will be discussed today. Next slide, please. So our top line results are focused on the findings in the knee joint by quantitative MRI. We've seen cartilage thickness and volume, which is considered the most important feature of OA disease, because as I mentioned, as the cartilage breaks down, that's when the other structures then begin to take over on abnormal wear and tear as well. And the strength and the health of the cartilage are predictive of subsequent knee surgery requirements in OA sufferers. And as OA progresses in the knee, the medial side of the knee tends to lose more cartilage more rapidly than the lateral side. And that's just based on where the weight and wear and tear is on the cartilage. So reduction in cartilage loss may therefore delay the time to total knee replacement in an osteoarthritic knee. With the natural progression of OA, knees with radiographic evidence is called KL grades of 2 to 4. So these are the patients in our study, would be expected to have an annual loss in the thickness of cartilage of around 50 microns and loss in cartilage volume of about a decrease of 4% annually at the central medial femur region. So remember, I showed you a diagram showing the medial regions, and so these are reported findings that are expected in terms of the natural history of the disease. A patient with OA will lose cartilage thickness at this rate annually. Next slide. What we've seen with twice-weekly PPS injections given for 6 weeks is that we've seen a consistent pattern across the regions of cartilage thickening over the 6 months of follow-up. We've seen that the placebo arm showed a loss in cartilage thickness in all medial compartments at 6 months. PPS increased the cartilage thickness in the central medial femur region by 60 microns, and this is compared to a reduction in the placebo arm of minus 20 microns at 6 months. So keeping in mind that we said previously the natural history is a decrease in cartilage at a rate of about 40 microns per year, we've seen the 20 in 6 months in our placebo arm, so that's very consistent with the natural history of disease. So if you just look to the left side at the bar chart, you will see for the medial regions of the cartilage, the PPS arm in blue showing increase in the central medial femur, the medial femoral tibial compartment, and the medial tibial compartment, all compared to decreases in the thickness of cartilage at 6 months. So this is a finding to keep this image in your minds, because what this is showing is the natural history is in red on this bar chart. And the difference with PPS is what we're seeing in blue. We're not seeing it stay at baseline. We're seeing it increase compared to placebo. So cartilage thickness has increased compared to the loss seen in the placebo arm. Next slide. Cartilage volume is another measure that is done by quantitative MRI. PPS showed an average increase in cartilage volume of 4.6% in the medial femoral tibial compartment compared to the baseline, where the placebo arm shows a loss of negative 1.7%. This is telling us that PPS is reversing the breakdown of cartilage at 6 months compared to placebo, which is showing the natural history of continued loss of cartilage volume. And the loss from baseline is consistent with a natural history of 4% in a year. So we're seeing here in our placebo arm a decrease in 1.7% over the 6-month period in just this compartment as well. And again, here it is visually on the left side, the percentage change from baseline in cartilage thickness, the PPS in blue, where the volume is increasing over 6 months, and the red is the placebo showing us the documented natural history of loss in cartilage volume over time in patients with KL grade 2 to 4 osteoarthritis. The next slide, please. So here is a representative MRI image, and I'll hand over to Dr. Mukesh Ahuja, who has much experience in interpreting these, and he's going to share some findings of this MRI with the audience.
Thank you, Donna. So these images, just a little bit background about, these are some sample images from our study patients from the randomized control trial. So these images are gadolinium contrast. These are contrast enhanced 3-dimensional MR images. In this particular image, we used to measure the cartilage thickness and cartilage volume. So the method that we use is it's an automated method and a machine learning algorithm, which is widely used in medical imaging analysis. So this method evaluates segments of anatomical regions from images to sub-millimeter accuracy with increased responsiveness to change. So the top 2 images, and by the way, these are sagittal images. So sagittal is an anatomical plane which divides the body into lateral and medial sections. So the top 2 images are from a patient who received placebo. The left image is at the baseline time point prior to the study intervention. And the image on the right side is at 6 months post-treatment, or 6 months into the study. So with this image, we observed that the patient was randomized into the placebo arm, and we observed at 6 months that there was a thinning of cartilage in the medial compartment on the tibia surface. That's where the pointer is, the arrow is indicating. The bottom 2 images are from a patient who was randomized to PPS twice weekly group. And the one on the left side is from baseline prior to treatment with PPS. And as we can see, there was a small bone marrow lesion, which is resolved at 6 month time point. In addition to that, we also observed there was a cartilage thickness in the medial compartment on the tibial surface. Next slide, please. So I'll hand this over back to Donna.
Thank you, Mukesh. So additionally, we evaluated the bone marrow lesion size, and bone marrow lesions appear as an increased signal intensity within the bone marrow, and they are finding that is common in knee OA and is believed to be related to microtrauma resulting from overloading of the bone caused by loss of the normal weight-bearing function of articular cartilage. So as that cartilage wears down and is not there to protect the surface of the bone, we start to see trauma and underlying subchondral bone marrow lesions. Increasing presence of bone marrow lesions is predictive of increased cartilage loss, and like cartilage loss, bone marrow lesions have been shown to be predictive of subsequent knee replacement requirement. Next slide. So here we see our results. Overall, bone marrow volume in the knee was reduced. Bone marrow lesion volume was reduced on average by 17.6% in the PPS twice weekly arm, compared to a 2% increase in bone marrow lesions in the placebo group. And this reduction in bone marrow lesions is consistent with reduced inflammation as well as cartilage preservation based on the relationship between bone marrow lesions, cartilage damage, and also inflammation in the joint. The image on the left side is showing us what I've just described. The blue is PPS, so the percent change from baseline in bone marrow lesions overall is down by 17.6% and has increased in the placebo arm. So this is over 6 months following a 6-week course of PPS treatment or placebo. We're seeing visible changes and measurable changes in bone marrow lesions. And on the next slide, we'll look at the MRI again with Dr. Ahuja.
Thank you, Donna. So this slide shows the bone marrow lesions or the changes in bone marrow lesions from our study patients. For bone marrow lesion assessment, we used a quantitative analysis technique or method in which the fluid was, the images were enhanced using color pixelation. So that's why we see there are some marks which are enhanced yellow/orange color. So those represents inflammation. So there's fluid in these areas or in defects which represent bone marrow lesions. So the top 2 images are from a patient who received a placebo saline injection. And then the image on the left side is, again, from the baseline time point prior to the treatment. This represents a femur. So where there's a dark area, that's the bone underneath, that's the spongy bone and femur. On the right side, the image on the top right side, as we can see, there is a bone marrow lesion formation, which was not there 6 months prior. So this is called the subchondral bone lesion. It's under the subchondral bone. So there's a development of subchondral bone lesion at 6 months in placebo patient. And the other image, the 2 images in the bottom, these are from a patient who received PPS twice weekly. At baseline time point, this patient represented with a bone marrow lesion in the middle femur, central middle femur, in the middle compartment. And we can see that there was a bone marrow lesion, which is marked orange color. It's circled in orange. And at 6 month time point after treatment, the bone marrow lesion was completely resolved. Thank you. Next slide, please. Back to Dr. Skerrett.
Thank you. So the next area we addressed in the quantitative analysis was synovitis or synovial joint inflammation. In OA, the synovial membrane can become inflamed and thickened in response to joint degeneration. And this inflammation causes increased synovial fluid production. Excess synovial fluid can lead to joint swelling and can be associated with increased pain and stiffness. So you see in the illustrations here on the left side in the normal knee joint, we have synovial fluid, and we see that the membrane is intact. And on the right, we see where we have cartilage breakdown, we have bone erosion, we have a swollen, inflamed synovial membrane, and we see that bulging out or the increased fluid in the joint as well. Next slide, please. So our results have shown changes in synovitis from baseline as well. At day 168 in this phase 2 clinical trial, synovitis increased from baseline in the placebo arm at a rate of 4.6% compared to a slight decrease of 1% in the twice-weekly arm. MRI images analyzed from baseline and at 6 months following PPS twice weekly versus placebo demonstrate an overall reduction in the intensity of synovitis. So what we're saying here is that the percentage change in synovitis on the graph on the left shows that we have an increase of 4.6% in the placebo group and a decrease in the PPS arm. And likewise, when measuring the image intensity due to synovitis, we see there as well that we have an overall reduction in the intensity of synovitis with the PPS group compared to control. Next slide. And here are some images for Dr. Mukesh to comment on.
Thank you. So again, once again, this is a sagittal section for patients who are randomized in a study. The top two images, now all four of these images are color pixel enhanced. Where we see yellow color, that represents that there is a high inflammation going on. So that's why it's there's intense synovitis. This represents intense synovitis with high intensity. So we measured the surface, the area, as well as the intensity of synovitis. So there's an inflammation going on due to osteoarthritis in the synovial membrane. So the top two images are from a patient randomized to the placebo group, and we can see that there was a synovitis is shown in the lateral recess. If I remember this correctly, this was 80% increase. This patient had an 83% increase in synovitis at 6-month time point compared to baseline. The bottom two images are from a patient which was randomized to PPS twice weekly group. At baseline, we can clearly see that there was a significant synovitis with yellow color showing there. And then at 6 months, the synovitis has reduced. So by the way, so all these images from placebo patients are from one patient who basically showed increase in synovitis, BML, and cartilage loss at 6 months post-op. 6 months post-treatment. Thank you. Next slide. Back to Dr. Skerrett.
Thank you. So in summary, this randomized controlled trial, PARA-OA-008, has demonstrated two very important aspects of measuring outcome in osteoarthritis. iPPS has demonstrated efficacy on both objective and subjective measures compared to placebo. What are the objective measures? These are things that we've measured, such as biomarkers in synovial fluid, biomarkers in blood and urine, and we've seen improvement in these biomarkers associated, known to be associated with OA disease progression, and we reported that out at days 56 and day 168. And also an objective measure is the measurement of structural changes by MRI. And we've reported that to you today, that we see improvement in structural changes in the knee, MRI representing improvement in cartilage, improvement in bone marrow lesions, and improvement in synovial inflammation at day 168. So those are the objective measures. And they are also shown to go along very nicely with the subjective or clinical data measures that we have as tools to use. So we've reported significant improvement in the mean change from baseline in WOMAC pain, function, and overall WOMAC scores at day 56, 168, and day 365. So all the way out to 1 year, we're seeing improvement in pain and function. And we've also reported out in this patient reported outcome, the PGIC, Patient Global Impression of Change, significant improvement in this at day 365. So a year out, patients who've received the twice weekly dose of PPS are reporting significant improvement in how they feel overall, significant improvement in their pain and function. And they're showing us by their biomarkers and by their MRI changes that these are all going together, the clinical as well as the structural changes that we've reported today. So taken together, these are very important findings to keep in mind when assessing our program, because generally programs will show improvement in subjective without objective. It's very hard to see clinical improvement along with MRI changes at 6 months and with the chemical biomarkers that are also pulling together the underlying mechanisms of why these changes are being seen. Next slide. So where are we going from here? We've had some discussion at last week's presentation that PPS, the optimal dose for our subsequent program, has been determined to be 2 milligrams per kg twice weekly. And where is that coming from? Well, we have extensive clinical experience with the 2 milligram per kg twice weekly dose regimen through PARA-005, a randomized controlled study of 121 patients, PARA-008, which we're speaking about to you today, which has 61 participants, and then our special access scheme in Australia, which has treated over 600 patients, and we have captured outcome measures in the majority of those patients as well. In our phase 3 program, we have a 2-stage adaptive design. And the first stage of that required us to evaluate, to identify the minimal effective dose that was a requirement or a request from regulatory authorities. So our first stage of that program has evaluated doses lower than the dose that we have the most experience with. And now that we've seen the data from PARA-008, and as we presented last week, have undertaken an interim analysis evaluating subjects from PARA-002, we have determined that we need to proceed in our program with the dose of 2 milligrams per kg twice weekly for further development. And that's based on the above noted clinical experience, the findings you've seen in this presentation and last week's presentation, as well as the dose finding results that we've obtained. So moving forward, we'll be working with this dose. We will be coming back to describe the progress with moving forward with the program. And I'll hand this over now to Simon to wrap up the webinar. Thank you.
Thank you, Donna, Mukesh, and Paul for the presentation this morning. That concludes today's webinar, investor webinar. And again, for any questions from today's presentation or any of Paradigm's other programs, please email investorrelations@paradigmbiopharma.com, and the team will be in contact with you as soon as possible. Thanks everyone for joining the session and participating. We look forward to our next update. Bye for now.